From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello and welcome to our listeners around the world. You're listening to JAMA Ophthalmology Author Interviews, and thank you all for joining us. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to look at a randomized clinical trial evaluating the success of corneal grafts in Descemet membrane endothelial keratoplasty, which goes by the name DMEK, and looking at those corneal grafts and their success, depending on whether the donor cornea is from an individual with diabetes or without diabetes. And joining me is the corresponding author of that report, Dr. Jonathan Lass. Dr. Lass is a professor of ophthalmology at Case Western Reserve University in Cleveland, Ohio. And he'll be discussing this investigation on behalf of the Diabetes Endothelial Keratoplasty Study Group. This is a study group sponsored by the National Eye Institute of the National Institutes of Health of the U.S. Department of Health and Human Services. Jonathan, thank you so much for joining us.
Great to be here, Neil, and thank you for the opportunity to speak on our two papers.
So let me ask you, how common is DMEK in the United States? Can you give me just a ballpark estimate? How many donor corneas do you actually need for these each year?
It's relatively recent, and it only really started taking off around 20 years ago and has now become the predominant endothelial keratoplasty procedure. Even the 2024 data that just came out from the EBA statistical report, it is now the dominant procedure for managing Fuchs dystrophy, more so than Descemet stripping automated endothelial keratoplasty. And there are very few any more transplants being done with penetrating keratoplasty for Fuchs. So there were about, I'd have to check on the numbers, I'd have to pull that up, but there's about over 20,000 of these being done a year.
So over 20,000 is certainly significant. And maybe I could presume that typically in the United States, donors who had diabetes were not going to be considered to be used for this procedure. Is that correct?
Well, I mean, the idea of doing this randomized trial was actually over 10 years ago. And it was recognized that when DMEK really started becoming a popular procedure, that there was a higher failure rate in preparing the donor and then compared to a donor without diabetes. And this sort of inspired people from looking back at the past literature that diabetes does affect the endothelium, and in vitro studies, in some spectrum microscopy studies, et cetera. So this is when we got the idea of doing this randomized trial to really look at the issue not only of the preparation failure question, but also the short and long-term effects of diabetes from the donor on the transplant outcome. So that's what led to the study. The other issue, main issue, was that we recognize that 30 to 40% of the donor pool are coming from donors with diabetes. So we really wanted to try to sort out which donors with diabetes can we use and which ones we can't. And the other concern was in designing the trial that we saw from the American Diabetes Association data that there's a high percentage of undiagnosed diabetes in the population. So we made sure then in developing a randomized trial that we would have a very defined group of donors with diabetes and those ones without. So we actually did a pilot study that did hemoglobin A1C testing post-mortem, which had never been done before. And we showed that within 90 days of death, that A1C was a reliable way of determining the diabetes state as defined of over 6.5% in the A1C. So that was also implemented in the study to make sure that the donors with diabetes had diabetes and those without were without. And we would appropriately assign, if the eye bank determined that the donor was without diabetes and yet the A1C came back over 6.5, then they would be reassigned into the group with diabetes.
So this makes a lot of sense, and I understand the importance of this. How are you going to define success? So if you were going to say this graft was a success at 1 year later, what made it a success?
The clinician, through a standardized approach of assessing the clarity of the recipient's stroma overlying the graft, that it was clear. That was the defining endpoint for the study at 1 year.
And if you were going to be worried about the donors that had diabetes, I presume that this was set up in a way that you thought there'd be a certain amount of success with those that don't have diabetes. What was that success you were anticipating? Not what you found, but when you were designing the study.
We drove our sample size ultimately with a 5% difference in success rate at 1 year. So we were expecting a failure rate of about 4% in the group without diabetes and about 9% in the group with diabetes. So looking for about a 5% difference, which was both clinically and statistically of value.
So a really high bar. I mean, you have 96% with success there that you were anticipating, and you said, we're not letting it be worse than 91%, something like that. Is that right? So how many people did you need for that? That's a relatively large trial in my mind, just ballpark on the back of a napkin when you're looking at, we're not going to accept more than a 5% difference. We want to be confident there's no more than a 5% difference.
Influenced by our previous cornea donor study and the cornea preservation time study, we actually needed about 1,420 eyes. 2/3 of the eyes would be in the group without diabetes and 1/3 with. And the reason why we did that split, it was a minimization procedure, it's not 1-for-1. We did that because that was approximately what the current rate of diabetes in the donor population was. This helped us in terms of the consent process, that your chance of getting a donor with diabetes was about the same as if you weren't in that trial. So that's how we designed it.
And one more question in the design before we actually get to the results. So this is really a big study. It's perhaps going to give us a definitive answer about whether there should be a substantial concern of donors who have diabetes or not. How will we be able to think about generalizing this across the United States? Was this at one or two big centers? How many places were participating in this trial?
Well, that's another thing. To truly have a valid multi-center look at what's going on with this question, we ultimately involved 28 clinical sites, 13 eye banks around the country, and made sure that any one investigator would not contribute more than 20% of the cases. And we weren't anywhere near that. So it truly was a multi-center, 46 surgeons involved in the trial. They all needed to qualify to be participating, and that they had to have at least done 50 cases with a primary failure rate and rebubbling rate. And so all of our surgeons were excellent DMEK surgeons.
Yeah, that seems really important because you wouldn't want to find an answer and then people say, well, but that's just with that surgeon who does more DMEK than anyone in the world. So let's get to the results here. So with that number of people that were randomly assigned in the fashion that you described, how well did the group without diabetes do? Did they meet your expectations?
We ultimately enrolled 1,097 individuals, contributing 1,421 eyes. We did have bilateral cases as well. And if they got a cornea from a patient without diabetes in one eye, the other eye would get one with diabetes. I was masked for the whole trial. Our whole team was masked. When finally the results were revealed, it was remarkable that 96% of the donors without diabetes did well with clear grafts at 1 year, and 97% with the donors with diabetes also did well. So there was absolutely no difference in the success rate for those donors with and without diabetes. It should be pointed out that 9% of the donors, 9% of the donors were reassigned. In other words, the eye banks didn't think the donor had diabetes, the care team didn't, the patient, and yet 9% were reassigned to the diabetes group. So that was an interesting finding. We also looked at diabetes severity and used a scale that had been published actually it was initially used to determine whether that donor should be prepped for a DMEK or not. Many eye banks were avoiding donors, particularly that had more severe diabetes, including ones that had complications such as retinopathy or neuropathy or vascular complications. So we looked at the whole spectrum of diabetes severity, and that also showed no difference. So even the severe diabetics did as well as actually the mild diabetic in terms of their graft success.
So it seems no matter how you looked at it, you pretty much definitively could say having diabetes in the cornea donor is not anything to be concerned about regarding graft success.
Now, one thing we are going to be looking at with future papers was the PrEP failure rate, because that was one of the drivers for doing the study. And we did report in the graft success paper, and we'll provide more details in future papers. But the preparation failure rate was, as I said, one of the reasons that was inspired the study. And we found that the preparation failure rate was 1.6%. And I should point out 1.6% in the donors without diabetes. And it was 6% in the donors with diabetes. And I should point out that the technician that was doing the preparation, peeling the endothelium with Descemet's membrane, was masked as to the status of the diabetes in the donor or not. So they were masked. So that was important. And so we did show that there was a significant difference in the preparation rate. So the story that we see is that if you can get through a successful preparation, that the donors do well, but there is this higher preparation rate. So we are looking at those factors, particularly related to diabetes severity, as to that difference. So that was an important finding. But having said that, the primary donor failure rate, in other words, grafts that failed with a cloudy cornea within 8 weeks after the surgery, was also comparable between the two groups. Most of the failures occurred early on in both groups, and they were similar.
So it may be a little harder to prepare in the donors that had diabetes, but maybe in the end, if you take that into account, your graft success rate will be the same. No reason not to consider those corneas.
Right. I mean, I think eye banks will have to take that into consideration, that there might be a somewhat higher preparation rate, but once it's successfully done, there appears to be no difference. There have been studies on the basement membrane of the endothelium, the Descemet, in diabetes. So there may be greater adhesion between the endothelium and its basement membrane in diabetes. That may be accounting for this higher preparation problem.
And also, you looked at the endothelial cell loss 1 year after the DMEK was done successfully. And just looking at that morphometrically, did you see any difference between the donors that had diabetes and the donors that did not have diabetes?
Well, as far as the cell counts, at baseline, both groups were amazingly matched. There was only like a 4 cells per millimeter squared difference. So the baseline cell counts were similar in both groups. And at the end, at 1 year, of those grafts that were clear at 1 year, 28% cell loss in both groups, exactly the same. So the cell loss was exactly the same. And we also looked at severity, and that didn't seem to have an influence.
Any limitations to the analyses, or we can be pretty confident about this? Any safety issues that were rare but didn't affect the overall results?
Not really. I mean, we worked really hard on managing bias and any confounding factors, and we kept one procedure, just DMEK, and didn't look at any other procedures. So really no significant limiting factors here. We were appropriately powered. So I think there's a clear answer here that donors with or without the diabetes do well, even based on severity.
So, as a cornea surgeon, is this going to change how you think about these donors with diabetes, or should our cornea surgeons around the country or even around the world be changing any mindset they might have, any hesitation they might have about taking a cornea from someone with diabetes?
I think both eye banks can now, obviously, they'll have to make a decision about the PrEP failure issue. But having said that, many eye banks were avoiding donors with diabetes for DMEK, and now they can clearly perceive that there's no difference. And surgeons should know when that cornea is handed to them after preparation that there's no difference when they're going to be using that tissue for DMEK. And I would say that given that we're really looking at endothelial biology or pathobiology, it certainly could apply for other procedures as well in terms of endothelial health.
Well, that's really important. I think that's going to change practice. I thank you on behalf of the Diabetes Endothelial Keratoplasty Study Group for your hard work on this, over 10 years of planning and then operating and now publishing the results. Jonathan, thanks to you and your colleagues for sharing this information with us.
Neil, I would like to add that we just recently learned, we would say that this is 1 year data, and we felt 1 year would be sufficient to answer a question, particularly in terms of the early effects of diabetes. And that's why we saw on the primary donor failure rate. But we also wanted to know long-term effects. So we did apply for a extension of following a sub-cohort of it. And we just recently learned that we have been funded for another 5 years to look at long-term effects of donor and recipient diabetes. So we're getting geared up for doing that study. So we may back to see you in 2030 with those long-term results.
Absolutely. We'll be here. That's really important. And thank you again for sharing all this really important information for the DMEK surgeons, the DMEK patients of the world. Thank you, Jonathan.
Thank you.
I'm Neil Bressler, and I've been speaking with Dr. Jonathan Lass at the Department of Ophthalmology at Case Western Reserve University in Cleveland, Ohio, who has been working with the Diabetes Endothelial Keratoplasty Study Group on an investigation into donor diabetes status and DMEK success at 1 year, showing us having diabetes or not having diabetes really has little, if any, effect on the success of those graphs. You can find a link to this article in this episode's description, and this episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks, everyone, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.